Hello, and welcome back to Wilderness Medicine Updates, the show for providers at the edges. I'm your host, Dr. Patrick Fink. Today, we're going to talk about airway management in austere situations, and we're going to use a real-life case. I'm pleased to have Dr. Nicholas.E.Weinberg join us today to discuss a case that he published in the Wilderness Medicine Journal. Look in the show notes for a link to that and some pictures related to the case. I'm excited to bring this material to you because I feel like these situations of high acuity patients where you're making consequential decisions with advanced interventions are not all that common in wilderness medicine, search and rescue. We just have a low volume of similar cases, and so it's useful to be able to learn from one another, to hear about someone's thought process, why they made certain decisions, even if maybe you don't agree with them in all points. Not saying that that's how I feel about Dr. Weinberg. Dr. Weinberg is an emergency physician at Dartmouth Medical Center and an assistant professor at Dartmouth's Geisel School of Medicine. He serves as the assistant director of Dartmouth's Wilderness Medicine Fellowship, and he has practiced expedition and wilderness medicine around the world. Notably, Dr. Weinberg just returned from a patrol on the National Park Service high-altitude patrol on Denali, and he is known for his extensive experience in mountain and wilderness rescue medicine. Without further ado, I want to bring you straight into my conversation with Dr. Weinberg. I hope you enjoy. Why don't we just start with, how do you tell people what you do, and where does wilderness medicine fit into your career?
So I am an emergency physician at Dartmouth Hitchcock Medical Center, and I'm at the medical school at Dartmouth, an assistant professor, and I'm an assistant director of our Wilderness Medicine Fellowship here. And also I am involved in ultrasound as well. I did an ultrasound fellowship. So I kind of wear two hats here. And before medical school, I was a climber and a mountain guide, ski patroller, ski instructor, offshore sailor, climbing bum, dirtbag traveler. And then I went kind of back. I went to medical school after I was in a climbing accident many years ago with a friend of mine, and I evacuated him with some basic woofer training and had this epiphany that I wanted to do wilderness medicine. So I went to a conference in Steamboat many years ago, and most of the folks there were emergency medicine physicians that worked part-time in the ER and did lots of other cool stuff. So they said, yeah, it's great. You can do emergency medicine and work part-time in the ER and then do wilderness medicine stuff in your other time. So that was kind of my goal going back. And then I went to medical school in Vermont, the University of Vermont. And then I worked at a community hospital in the Adirondacks in upstate New York for a few years, and which allowed me to do a lot of wilderness medicine stuff. I worked in Nepal for the Himalayan Rescue Association. I did patrols on Denali. I worked on a ship that sails around the world, a square rigger as the physician, crossing the Indian Ocean for 4 months. So I did a bunch of stuff like that. And then I kind of wanted to get back into academics. So I did an ultrasound fellowship in Boston at Mass General, and then ended up in New Hampshire at Dartmouth. Yeah, that's kind of an abbreviated version of my story.
Great. Well, I was really happy to see the two cases that you published in Wilderness and Environmental Medicine, because I think these kinds of cases are useful for learning purposes, but the frequency of these high acuity cases is relatively low in any given rescue outfit or SAR group. So it's hard to chase them down and get them out there in a HIPAA compliant format. And so when I saw this paper come across my desk, I was like, I got to find this guy. So
Yeah,
let's start with.
Yeah, it was kind of an unusual paper to publish. And we were kind of threading the line of, HIPAA compliance. And, I think we were compliant. And actually the fallen climber, she reached out to me. I can tell you that this is an interesting part of the story, actually, and gave me permission to publish this and to help other people learn from this experience.
That's awesome.
Yeah.
Well, let me just start with the first paragraph of this case, and then I'll have you lead us in.
Sure.
In the White Mountains of New Hampshire, a rock climber in her 30s and her partner scrambled unroped through Class 5 technical terrain to reach a crag. The climber slipped and fell approximately 12 meters or 40 feet down a loose gully onto a steep exposed ledge. A nearby pair of climbers, including an emergency physician, heard the fall, followed by calls for assistance. The EP had technical climbing experience and training in mountain rescue. He scrambled up the ledge to access the victim. Meanwhile, his partner used a cell phone to call for medical assistance and organized a team of nearby climbers to perform a litter rescue. So let's just get it out there right up front. You are the emergency physician in this case, right?
I am, yeah.
Can you walk us through the moment when you first arrived on this scene? What did you see? What was going through your mind as you approached this woman?
Yeah. So, I was at this crag, which is a fairly popular climbing area in New Hampshire. And I heard this loud thud sound that if you have ever heard the sound of a climber falling, it's the sound that you never forget. And I immediately knew that it was a bad event and that someone had fallen pretty far just from the sound of it. But then I didn't hear any noises, and I thought, okay, maybe it was just a tree that fell in the woods. Sometimes you hear a random tree fall. And then like a minute later, we heard calls for help and then knew that someone was pretty badly injured. So, being a physician, experienced and trained in mountain rescue, I wanted to assist. And so I climbed up to this ledge that this patient was on and kind of found her there. So she had fallen and was basically kind of upside down, head first on this ledge. And she was breathing, but really wasn't protecting her airway at all, which was pretty dramatic. I mean, we learn a lot about airway maneuvers in emergency medicine, and it's pretty rare to have someone with absolutely no airway reflex. And she really didn't have any airway reflex. So it was kind of like basic first aid stuff that you're taught in wilderness first aid courses. And, I did a jaw thrust and opened her airway. And her partner was with her and was very shaken up, not really very functional. So we kind of calmed him down and reassured him. And then I realized that she was going to require a technical rescue because it was on this exposed ledge up on a steep hillside. So I made the decision to leave her there after we had kind of talked her partner down and kind of calmed him down a bit and then taught him how to do a jaw thrust. And he was able to do that effectively. So I felt that my skills would be better applied kind of running this rescue and getting the right resources that we would need for this particular rescue.
What did it take to get to that ledge? What kind of terrain was between you and there?
There was kind of some moderate scrambling, maybe kind of 5'5", 5'6" climbing terrain. I don't know if you're a climber, but
yeah.
So I mean, if it was a little bit exposed, but for an experienced climber, it wasn't. I was comfortable kind of soloing that.
Mm-hmm.
Yeah.
And were there any concerns about either your security or the patient's security on the ledge? Like
the ledge was
proximity to the edge, potential for an additional.
Yeah, she was on this kind of exposed ramp where it was not an ideal place to kind of package her and kind of initiate care. And so the first thing I wanted to do was move her down to this lower ledge, a few feet down, where there was more space to work with, and it was less exposed because I obviously didn't want someone else, to create additional victims. So we
And did you do that during your?
So we a bunch of us basically beamed her down to this other ledge.
Okay.
Yeah.
So you then descend off of the ledge to start coordinating rescue for her?
Yeah. So the partner we left him kind of holding her in a jaw thrust position, immobilizing her. And then my climbing partner, who didn't have any medical experience, basically organized a rescue, a team of litter carriers, essentially, of other climbers, and also called for 911 on his cell phone. And then I scrambled eventually down to a parking area where I met the EMS crew that was first on scene. And I used to work in a community hospital near this area. And I knew the paramedic who was on, who was also a climber. So it was very convenient. And I basically told him the story and that explained that this woman probably needed, to be intubated and needed RSI meds. So we basically packed up all of their RSI gear and brought it up to this ledge. So it's a pretty unique scenario where we were far enough from the road that she needed a carry out and technical lowers, but close enough that, that street paramedics, well, it's a rural area, but the paramedics could make it up there. So that's what made it kind of an interesting case.
How long do you think it was between going to take to leave the patient, get the paramedic, come back?
Probably 45 minutes, maybe 30 to 45 minutes. Yeah.
And when you returned to that ledge with the paramedic, did you appreciate any change in her condition at that?
He really was about the same. Really still not protecting her airway, her very low GCS, basically unresponsive to even painful stimuli.
Yeah. So I think for the emergency physicians listening, that tells a pretty stark story. But for those maybe with less medical training, what was going through your mind about the nature of her injuries and what you might be facing?
Yeah, I mean, so she fell, and the way she had landed kind of upside down, head first, I was very concerned about C-spine injuries, which she ended up having several cervical spine fractures, unstable fractures. And she ended up being neurologically intact in terms of a C-spine injury, but she had several unstable C-spine fractures. And then she ended up having subdural subarachnoid hemorrhages and intraparenchymal bleeds as well. So yeah, my biggest concern was kind of C-spine immobilization. We kind of controlled her airway by just a jaw thrust, and that was working.
Yeah. I guess with that sustained altered mental status, it's telling you that she has a pretty significant head injury.
Yeah.
I imagine that if I had been in your place, I would have had some concern that she could herniate, she could deteriorate. You might be coming back to an even worse situation or someone who's died while you were gone.
Yeah, that definitely. But fortunately, she maintained a degree of stability, even though she was obviously very sick.
So it sounds like as you were returning, you were thinking through how you wanted to manage her airway. What factored into your decision to pursue rapid sequence intubation versus an LMA, sticking in an oral airway and continuing bag valve masking?
Yeah, I mean, I think in most wilderness situations, you're not going to have RSI available. I mean, it's not going to be an option. You'll have maybe an oral airway. But since it was kind of a unique case in that it was remote, but not remote enough to prevent, ALS crew from being on scene, essentially. So we had a lot more resources than you might have in a lot of other scenarios. And we had the experience and skill level to do RSI. And I knew that paramedic, I trusted him. He knew me, we'd worked together. And I knew that it was going to be somewhat technical carry out with some lowers, and that, an LMA wouldn't be ideal. Since she really needed an airway, we were able to do RSI. And we had a suction device, we had meds, RSI meds and sedation meds, and we had oxygen as well. And we had backups. We had LMA as a backup. So it seemed like a reasonable choice given
how obtunded and out of it she was.
Yeah.
And the potential for blood or vomitus in the airway. Did you consider not paralyzing her?
Yeah, that was my biggest concern, was that she would have blood or secretions in the airway, and that we would be out here with a mechanical suction device and not able to intubate her. And there were secretions and blood in her airway, but we were able to quickly suction it out, and it ended up being a non-issue. But yeah, that could have been, a point where things could have turned for the worse in different circumstances, for sure.
Yeah, when I imagine myself in your shoes, I'm feeling apprehension about paralyzing this patient. because of the, obviously suboptimal patient positioning. This patient is not on a gurney up at your sternal height where you're gonna be able to get a great angle into the larynx.
Yeah.
And I got a little puckered just thinking about it.
I guess, I don't know. Yeah. The other thing was paramedics are used to intubating people on the floor, lying down, so my colleague, the paramedic who was there, was very comfortable doing this. And I wanted him to intubate since, they don't get to intubate as often as we do. So, and I was there as kind of a backup. So I kind of walked him through it. But yeah, it could have, it worked. The other thing was she was otherwise young and healthy, and, I didn't think she would be a difficult airway, and she wasn't. So based on her anatomy and age.
Thinking your way down the airway algorithm, did you have things to perform a cricothyroidotomy if you needed to?
I don't believe we did. I don't know if the paramedics had a cric kit. They might, but I honestly can't remember. They might have.
Okay.
Yeah.
So then you've got this patient intubated despite the fact that she had blood in her airway and manual suction, which almost never seems to work.
Actually.
How the
situation.
That's great. That's like the first time I've ever heard of that. Every time is like one of those squeeze ones.
Yeah.
Where you have to like
it was actually the first time I've ever used one of those in a real scenario. And it worked surprisingly well.
You got your one that like never ever have worked for me.
I wonder.
But regardless, so you've got the tube in.
There are all these cheap fans you can get on Amazon. They must have like battery powered suction devices now that could be very powerful. Anyway, something to think about.
That's often like a terrible YouTube ad. It's like, this device will blow up the internet, and it's like some tiny little vacuum cleaner like that. Maybe that's all you need.
Yeah. Well, I mean, whenever I'm, setting up for intubation with the residents, suction is the most important thing in my mind, making sure it's there and working.
Yeah.
Yeah.
If you can't see, then that makes everything nearly impossible.
Yeah.
So how did you secure the endotracheal tube?
We had tape and just, the paramedics had kind of I kind of let them do their thing. I was there guiding them and being the point person, but I let them do the small stuff like securing the tube the way they do it. Yeah.
So then you eventually get her packaged into a litter. She needs at least like one technical lower off this ledge.
Yeah.
How did you continue to ventilate her during that process?
Yeah. So we had attendants that were bagging her while she was being lowered. So, which worked well. It was steep, but it wasn't a vertical lower. I would say it was maybe 50 to 60 degrees.
So did you have multiple attendants on the litter then?
Yeah.
Okay. Yeah, that's helpful.
Yeah. Yeah.
Okay. Yeah. And then you mentioned some of her injuries. So she had unstable cervical spine injuries, multiple varieties of intracranial hemorrhage.
Yeah.
How did she end up doing clinically?
She also had a basilar skull fracture. It was mostly kind of from C-spine up were her injuries, but they were very severe. And so eventually we carried her down and transferred her to DART, which is the name of our air medical service at Dartmouth. And they landed in a nearby field and flew her to Dartmouth to our hospital. And she was evaluated as a trauma patient, admitted to the surgical ICU. And she had a very complicated course. She was in a pentobarb coma because of increased ICP. She was on continuous EEG monitoring. She was trached and pegged. And basically, so this is actually a good story. I remember one of my residents was rotating in the ICU, and I would talk to him about her getting updates. And I guess the teams were continually trying to convince the family to withdraw care because her condition was that poor. And eventually she went back to where she got transferred back to her home state and was craked and pegged in a nursing facility for several months. And I kind of assumed that was it, and she would be in this persistent vegetative state, etc. And one day when I was working in the ED, her mother came to me and like found me in the ER and was very grateful because she thought I had, saved her daughter's life, etc. Anyway, so I stayed in touch with her mother. And anyway, about 6 months after this, I kind of had forgotten about her. I got a text from her, from the patient, basically explaining what had happened to her and thanking me for saving her life. And I said, wow, this text is fairly coherent. Like there was one little typo, I think. So she ended up having an amazing recovery and was functional. And she sent me a picture of her like playing guitar. And last I heard, she was writing a book or a memoir about her experience. So
Wow.
a happy ending to the story. Yeah. Which
Yeah, it's all
atypical, I think.
Yeah, everything about this case is remarkable, and
Yeah.
I don't think it was hyperbole to say that having someone with your combination of skill sets on the scene was incredibly fortunate for her.
Yeah. 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 I guess so. Yeah.
Well, it's always nice to have someone say thank you.
Yeah.
That doesn't
I know
happen
it
every
doesn't
day.
happen that often in the ERs.
Great. Well, I'd like to. I think we have time to move on to the second case if you're open to that.
Yeah.
And the two cases together do raise the question: like, are you a terrible black cloud on every expedition you go on?
I don't think so, actually, because I just got back from a month on Denali doing rescue work, and this was my third season up there, and it was actually very light in terms of SARS and stuff. There was a lot of frostbite because it was very cold, but there were not a lot of SARS or bad falls. So I think I used to be more of a black cloud, but now it's been shifted.
You've punched that card.
Yeah, yeah. Although I have had quite a few accidents. Once I was climbing in the Gunks, which is a climbing area in New York State, and kind of a similar episode where a climber fell right next to us, a 40-foot lead fall, and was basically hanging upside down, unresponsive, not protecting his airway. And we kind of evacuated him as well. He ended up getting intubated and flown and had severe head injuries as well. So I don't know. Maybe I am a black cloud. Maybe you don't want to be climbing next to me, I guess, is the moral of the story.
Or maybe you do. It's hard to say.
I don't know. I think the more time.
All right. Well,
and a lot of people ask me, like how to get interested in wilderness medicine, and I think, ironically, I was actually like playing hooky that day, and I was supposed to be at some conference, a wilderness medicine conference, and I decided to go climbing instead. And then that event ended up happening kind of serendipitously. And so I think what I tell people is like, if the more you get outside and do things, the more you will end up being in situations where you have to offer care or rescue people. So I guess my advice to young people interested in wilderness medicine is to just get out and recreate and spend a lot of time doing things, because you'll end up getting pulled into rescues. And I think as an emergency physician, people just whether you want to or not, they will look up to you, and you will end up kind of being the leader in these rescues often. So, which is kind of cool.
Yeah, it is. I mean, it's a very pertinent skill set in that we're used to being, kind of the leader of the team and assuming the risk and the decision making, which are the two elements that people are most willing to just hand off in one of those rescue situations.
Yeah. Yeah. Well, I think we're comfortable. We're so I think we take for granted actually how much risk we manage on a day-to-day basis in the ED. So in these situations, a lot of other people are incapacitated, but for us, we just have one patient, compared to what a busy day in the ED, you can have 40 patients that you're responsible for. So, I mean, to us, these like that scenario is actually not that challenging for what we're trained to do,
Right. The challenge is just the limited tool set, which on the flip side is also dramatically simplifies the decision making.
Yeah, and that's I think one of the reasons we decided to write this paper was because you have limited resources, and basically you do the best with what you can. And in some ways it's less stressful because you have less options to choose, less potential pathways. You kind of just doing the best you can. And it's a different
Yeah, when you're
care. And I think that was kind of one of the main reasons I wanted to write the papers, because it is a different standard of care, and just putting it out there that it's okay to function at a different standard of care from what we're used to in the ED.
Mhm.
I don't know how.
Well, let me introduce
Oh,
this second case and we can work through it and see the contrast.
Sure.
During a snowstorm, a guide escorted a middle-aged trekker on horseback from the village of Lobuche at 4,940 meters, or 16,000 feet, to the Himalayan Rescue Association clinic in Fariche. Am I saying that right?
Yeah, you got it. Sure.
Fariche, Nepal. The trekker had a Glasgow coma score of 9 and was tachypnic. Her guide told the 2 emergency physicians at the clinic that the trekker likely had high-altitude cerebral edema. She had spent the previous day in her room at a lodge with a headache. She had no reported respiratory symptoms. She had no known significant past medical history and had been at altitude before without problems. Where I want to start with this one is I think folks should look at the paper in the show notes and see the picture of the room that you're working in. Can you set the stage for us what this clinic looks like?
Yeah, sure. So the Himalayan Rescue Association is a nonprofit that's based in Kathmandu, Nepal. And their initial clinic was in this region, which is the Khumbu region, which is the Everest Valley, which is it's the most popular area in Nepal for trekking and obviously for climbers as well. And it was first developed in the 70s because they were seeing a lot of unnecessary morbidity and mortality in that region, mainly from altitude illness that could have been prevented. And so this foundation was developed. The first clinic was in Fariche, which is at 14,000 feet roughly. And it's a small clinic. It's a small stone hut, basically, with some solar electricity. And that's about it. And it's pretty basic in terms of resources. There's some oxygen tanks. There's a monitor, oxygen concentrators, an EKG machine. There's no imaging. There's limited medications. And then basically whatever supplies people have brought there over the years. And they also have another clinic in the Annapurna region on the Annapurna Circuit Trek. There's a pass that people go over that's 17,000 feet, and a lot of trekkers get altitude illness there. So the main reason there is to prevent altitude illness in trekkers there. And they take volunteer physicians for about 4 months, 3 to 4 months in the fall and spring seasons. So I did a season there. And it happens to be, it's probably the best place in the world to see and treat altitude illness if you're interested. I'll put a plug in for the HRA. Yeah. It's a fun time too.
The picture really looks like you're in a kind of crummy room of a hostel, and there's two beds, and there's a monitor and what looks like a climber's oxygen tank sitting on the bed, and you guys are both wearing like knitted caps, like it's not heated and it's cold in there.
Yeah, it's very cold. And that was towards the end of the season in, I think it was November. It gets quite cold up there. And that was in the middle of the night, actually. I was basically running a code in my long underwear, which was kind of funny. It's the only time I've run a code in my long underwear. But there's this giant school bell that they have out in front of the door, and people ring it. And so we were sleeping in the middle of the night and someone rang the bell. And then I opened the door, and there's this woman that looked like she was literally dying, and she was on horseback. And then as soon as we walked her over to a bed, she syncopized and basically went into a PEARS.
Yeah. So what were you thinking at that moment in terms of what might be going on with her? Don't ruin the punchline quite yet as to what is actually going on. But
so the Nepali guide that was with her basically said, "Oh, she has HAPE and HACE, that was his diagnosis." And most things at altitude are altitude related until proven otherwise. So kind of everything else is a diagnosis of exclusion. So most of the time, whatever these people come in with, it's usually related to the altitude. And when they go down, when they descend, whatever symptoms they had seem to go away. It's kind of like a dialysis patient where whatever symptoms they come in with seem to get better when they get dialyzed, similar with altitude illness. They get better when they go down. So, our first assumption was this is, you had HACE or something like that, or HAPE and HACE. is the most likely cause. And her oxygen saturation was unmeasurable. So we kind of assumed it was HAPE and HACE, and they can often be concomitant together. The only thing is she had clear lung sounds, which was a big clue to what she ended up having.
Mm-hmm.
Yeah.
Yeah. How did your initial suspicions guide your initial interventions?
So we just kind of empirically treated her for HAPE and HACE. So we put her on oxygen and we gave her IM dexamethasone. We didn't give her nifedipine. And then we basically bagged her. And she did regain pulses, but she didn't really perk up that much. And one thing about HAPE, which is high altitude pulmonary edema, is they often, and this is often a board exam question, they often get rapidly better with oxygen. And that can be used diagnostically too. Like, unlike someone with pneumonia that is still going to stay pretty sick and hypoxic, people with HAPE, because it's this inappropriate pulmonary vasoconstriction, as soon as you put them on oxygen, they get rapidly better. And that didn't happen to her. So that raised our suspicion that there was something else going on.
Talk to me about how, so you do CPR for a bit, you get pulses back, which is sort of remarkable in and of itself in someone who's got PEA and maybe just hypoxic versus intracranial cause of her arrest. She then doesn't have great initial respiratory effort. How were you thinking about managing her airway, both over the next hour or two, and then looking forward through her potential evacuation?
Yeah. Well, one other clue to the diagnosis is that she syncopized with exertion. And then once we kind of stopped exerting her, she did slowly get better and then regain kind of weak pulses. And she did slowly improve in terms of her mental status, but she still remained basically obtunded the whole night. And then the next morning, she was a lot more awake and alert after being on oxygen all night. So, we still thought there was probably a component of HAPE involved, which there may have been.
And what tools did you have to manage her airway, and how did you opt for one over the other?
Yeah, so, we had oxygen tanks, oxygen concentrators, masks. There was an assortment of endotracheal tubes that had been brought and left there. There had been some anesthesiologists who had worked there. There was a couple LMAs, a BVM. There's no ventilator, and just kind of a hodgepodge. I don't know if you do expedition medicine, you end up using kind of a hodgepodge of stuff. Like that sailboat I worked on, that tall ship, it was random stuff that people from all over the world had brought, different doctors over the years. So that's also kind of fun, is like you kind of use what you have. But there was a storm. We knew we weren't going to be able to fly her out for at least 24 hours. So the thought of intubating her and then just bagging her for 24 to 48 hours before we could fly her out just didn't seem that appealing. And she was very sick, but was kind of somewhat stable at this sick level. So we kind of made the decision to just watch and wait. And again, she was the only patient. If you were in a busy ER, you would just intubate her and move on, right? And she'd go upstairs to NICU. But we had the option to kind of monitor her closely. So we made the decision not to intubate her. And, the point of this paper was that both of these patients, if you presented them to any standard emergency department in a developed country, would get promptly intubated. And we kind of managed them differently based on the context.
Right. So you didn't feel like you wanted to be up all night bagging this patient, or potentially through the following day, even maybe employing the guide or whomever else to bag.
And also, we didn't have any I don't think we had any RSI meds. We didn't have sedation meds. You kind of, intubating someone is a commitment. Once you intubate them, you're committing to, maintaining them as sedated, which with the other patient, the climber, we could do that. And I knew that we were going to get her down to a helicopter who could, get her to a tertiary care center. So, yeah.
So by the following morning, she's a little bit more alert. Was she able to give you any additional history that helped you better understand what had happened?
So the following afternoon, I would say by the following afternoon, she could actually talk to us. And she said, she didn't have a headache at all, and that basically she'd been flying in her tent for a couple days, and then became really short of breath.
So she ends up being flown by a helicopter to a hospital in Kathmandu. And what did they find there?
So they worked her up, and they ended up scanning her chest with a CT and found that she had bilateral massive pulmonary emboli. And
Had she had any history of clots?
no history of clots. Yeah. And she flew back to Austria and ended up doing well, is what I heard.
That's another case that seems so improbable because cardiac arrest in the setting of massive pulmonary embolism doesn't usually turn out well, let alone in this austere setting.
Yeah. Yeah. Well, I think the fact that she kind of syncopized and arrested with ambulation, that's kind of a big clue in retrospect. I always have the residents kind of ambulate people if you're thinking about a PE, because they often get more symptomatic with ambulation. And she got very symptomatic, obviously. She went into arrest. So, that, but yeah, so she was kind of stable enough that, like, she made it through and got better overnight.
So you do a nice job in this paper. There's a great table that I would refer our readers or listeners to, talking about the different airway interventions, everything from a recovery position up through endotracheal intubation and a crike, and looking at the advantages and disadvantages of both of those, of each of those interventions. What strikes me is it's primarily an issue of, once you commit to the airway, what do you have to do to maintain it?
Yeah.
And that seems like kind of a critical point in both of these cases.
Yeah, and that's something that I don't think we have to really worry about in the ED, in our home environments, because there's always going to be a respiratory therapist who appears and kind of manages everything, gets the vent set up, and then they'll get eventually transferred to the ICU. And in these wilderness settings, you don't have that. So you really have to kind of think carefully about, what the ramifications of your actions, I think, and how you're going to manage this patient after you intubate them. So, yeah.
If you had a senior resident who's graduating and they're saying, Dr. Weinberg, I'm spending my next year up in the Himalaya, or I'm doing multiple patrols on Denali, how would you brief them or give them a mental framework for how to take their ER skills and apply them to that setting?
Where do I begin? Yeah, I think one of the main reasons we wrote the paper was to kind of teach people to be flexible and to maybe think about things and not just follow things blindly. But I often have junior residents that are so eager to intubate because someone's altered. And, again, like I said, that can be fine and convenient in the hospital, but in a wilderness setting, it may not be the best decision. And I wanted to write this paper so that if other people were in similar situations, you could kind of set a standard of care where there is no standard of care, actually. And that standard of care is fluid and can vary, but depending on where you are and what situation you're in and what resources you have. So I guess the biggest thing I would teach people is to be flexible and not jump into following an algorithm.
What was the setting of your community hospital that you worked in? Was that critical access?
I've worked in a few different critical access hospitals. I worked in a busy community hospital in upstate New York with very sick patient population without a lot of access to primary care. And so that and then I also worked in a small community critical access hospital in New Hampshire as well. And I think both of those helped prepare me a little bit for, austere settings where you don't have as many resources as you have in a busy academic center.
Mm-hmm. Yeah, I hear you talking about all the resources you have at Dartmouth, and I was thinking to myself about our practice site in Madras, Oregon, which is a critical access
Okay.
hospital that pretty small, pretty under-resourced overall.
Yeah.
And
Just cover
I was thinking about the fact that, yeah, we have 4 hospitals in the region, and Madras is one of them. And it's single coverage on the MD side. We have an APP during the daytime, but pretty limited number of nurses and lower experience with high acuity patients overall, but a pretty sick patient population with patients from the Warm Springs Indian Reservation, and we're along a highway corridor. And that kind of site, I think, is a great stepping stone after a residency in an academic center where you have all of the resources, because as soon as you're thrust into that situation, you realize how much you had farmed out mentally to the respiratory therapist, to the highly experienced trauma nursing staff. And all of a sudden you need to know how to set up the arterial line pressure bag or run the vent or what have you.
Yeah. I gave a grand rounds a few years ago on wilderness medicine, just because so many people would come up to me asking me how to get into it. And I have a couple slides on that topic where basically you're the nurse, the tech, you're the EKG tech, you're the respiratory therapist. So it's useful to just practice get comfortable doing all these other things that you don't usually do as a physician if you are going to be in remote areas, especially in a clinic like that in Nepal, where you do have some resources. You're expected to place IVs and put the EKG leads on, that sort of thing. So it's all stuff that you can learn pretty easily, but it can be, people can be caught off guard if they're not prepared for that.
Definitely. You could easily become task saturated in those things if you were unfamiliar and learning them in real time. Task saturated, even if you suddenly realize you have to do direct laryngoscopy, you don't have your video scope, and you haven't done that since your anesthesia rotation and residency.
Yeah, totally.
Well, Dr. Weinberg, I appreciate you talking through these 2 cases with us. I'm going to have the airway management paper in the show notes for people to have access to, and I'd encourage them to read it even after listening to this, because I think the analysis and some of the literature review on, for example, supraglottic airways in comparison to intubation in the pre-hospital environment is really useful, and it's a very concise, well-structured summary of that. If folks want to hear more from you, connect with you, where are you on social media? Do you have other things that we can point to?
I'm not really on social media, actually. I'm happy to, you can give my email out. I'm happy to field emails from people. Yeah. But I don't have a blog or a web page.
Okay. We'll put your academic email in the show notes if folks want to reach out with questions.
Yeah, I'm happy and happy to give people advice if they want to get interested in wilderness medicine and don't know kind of where to go, where to jump into it. I'm happy to give advice.
Awesome. Well, I really appreciate your time. The listeners of this show are very appreciative and courteous, at least in the interactions I've had with them. So hopefully you'll get some nice thank yous from them as well.
Great.
And I'd love to have you back on sometime, maybe to talk about the climbing accident that brought you into medicine.
Yeah, definitely. I'm happy to chat anytime. It was really fun chatting with you.
That's it for this episode of Wilderness Medicine Updates. I hope you enjoy that conversation with Dr. Weinberg and that you're able to take away some learnings or at least some mental simulation of a couple interesting cases. I do encourage you to look at the paper, which is in the show notes and makes a good read, as it does break down the pros and cons of different airway management techniques in austere situations. And I think it's worth thinking about in the situations where you commonly operate. What tools do you have available to you, and what are you actually capable of doing, and for how long? Because that is going to drive the care that you can deliver to a patient and the decisions you make about how you manage them. I, in my education for our ski patrollers, for example, like to harp on the fact that really it is that basic life support care that can actually make a difference for patients. And so just like Dr. Weinberg said, probably the biggest thing that he did for the patient in that first case was to do a jaw thrust, open the airway, a very simple maneuver that he can teach a climbing partner on a cliffside. But that in and of itself is a life-saving maneuver. those basic tools are the things that we can fall back on time and time again. And then if you're in the right place at the right time, like Dr. Weinberg was, can deliver some of that advanced care from the emergency department to the cliffside. I want to give a couple shout outs. I've been hearing from Bruce Petty and Heiko Stopsack. Thanks for reaching out. I appreciate the communication. You guys are awesome. I hope that you enjoyed the podcast. If you did, please give it a 5-star rating on iTunes, on Spotify. That helps us get out to more people, this passion project that I hope delivers benefit. The more people it can reach, the better. So tell your friend, your colleague, a doc, a nurse, a paramedic. Tell your mom. I think your mom might like this podcast. Until next time, you can connect with us on social media now. There is an Instagram. There's a Blue Sky. The information's in the show notes as well, or you can find it on the Buzzsprout page. James Hansen is our media manager, and he does an awesome job in his free time. So thanks to you, James. Until next time, I'm your host, Patrick Fink. Stay fit, stay focused, and have fun.